I'm just adding that to their story real quick.
Sounds good.
All right, we are live.
Okay, perfect.
Hello, everybody. How are you guys doing? Um, if you want to wait like a minute or two just to like let a few more people hop on.
Okay.
Um, we're you seeing a patient? Like, is it a busy day today?
Yeah, I do. Or I will share how many patients we typically see and stuff. But Mondays are my half day, so I'm only here for 5 hours. But I saw 18 patients today, so it is very busy. Yeah,
Wow.
but it's good. Once we are done, we're done though.
Right, right.
Yeah.
That's good. Like you have a set amount. So, how are
Yeah.
you guys doing today? Where are you guys from? Like, let's just get a gauge on the audience.
Yeah.
Lots of hellos.
Well,
But
how many people typically show up for them?
it depends. For our lives, we can have anywhere from like 200 to 300, but we allow people to go back and watch the sessions for credit. So we can typically get from anywhere like 1,000 to 5,000. Just depends on like how free people are. Yeah.
Yeah, no, I'm so glad you guys are doing this because it's been so hard. Like I've had multiple students reach out to me because it's hard to do in-office shadowing, right? So
Right.
having these virtual shadowing sessions, I think are helpful. I wish I had them when I was in training. Um,
Really? That's good.
yeah, so I'm glad. I'm sure it's a lot of work, but I'm sure a lot of people appreciate all the work you're doing. So no, thank you.
We appreciate that.
And
I
thank you
was
for
actually,
having me.
I'm sorry.
And I said, and thank you for having me on it.
Oh, no, thank you for giving up your time and joining us. Lots of, oh, happy International Women's Day. Just
Yeah.
remember, but,
A lot of
um,
strong women everywhere. So yeah,
mhm,
here's to strong women.
mhm. So do we want to go ahead and get started?
Yeah.
Go ahead. Um, Obviously, welcome back to virtual shadowing, guys. So today we have Dr. Paul, a dermatologist. And remember, if you guys have any questions, so leave questions in the chat, and we'll have a little Q&A portion, and I will ask questions on your guys' behalf. And in order to get your certification for your attendance, write a 4 to 5 sentence summary and send it to clubmedshoe@gmail.com. And you guys should get your certificates within a few weeks. If you guys are not sure about the guidelines, just go to our Instagram page and hop on to the guidelines tab in our the link in our bio, and that should tell you all the information that you guys need. And without further ado, I'll let Dr. Paul introduce herself.
All right. So hi everyone. Again, happy International Women's Day. I am really, really happy and thrilled to be a part of this shadowing experience. I was just saying how this stuff is very helpful because especially with the pandemic, I'm sure a lot of you are not able to go in person. So if we're able to give you an idea of what it means like, a day in the life of a dermatologist, that's my goal here. And I'm always happy to take questions. Also, you can reach me on my Instagram page, which is DRS Paul Derm. And moving on, I'll give you a little brief background introduction about me. So I'm originally from India. I grew up there. I moved to the States when I was 18 by myself. I was on a visa pretty much the whole time during my medical training. And anyone out there who's on a visa, it is very hard and challenging. But even if anyone ever tells you that, it can be done and all that kind of stuff, don't pay attention. A lot of times people are just not very familiar how to do it, but it can definitely be done. You can definitely go to any school or like good schools as well as competitive residencies such as dermatology, even if you're on a student visa. So for undergrad, I went to Cornell, and then for medical school, I did the combined program between Harvard and MIT, which is called an HST or Health Science and Technology program. So it was a little bit more research heavy. But then my last 2 years, the third and fourth year, was still very similar, where we spent all the time in the hospital. And then for for my prelim year, I actually did internal medicine at University of Miami. And then I stayed there for my dermatology residency for 3 years. And I was one of the chief residents when I graduated. And I graduated in 2019. So it's been a year and a half since I've been out and practicing. So now I'm a board certified dermatologist. I'm in a multi specialty group in Orange County, California. And, this is one thing that was very confusing for me. And not only when I was doing my dermatology residency, that's when I realized that there's actually multiple different practice setting for any outpatient specialty, but I'll speak specifically for dermatology. So just to give you an overview, even as a dermatologist, you could practice in academic institutions, so the ones that are affiliated with big schools, medical schools, and there are pros and cons to everything. But being in an academic setting, you have grand rounds and things like that, where if you have a very complicated patient, you can actually discuss it on a weekly basis and things like that. Also, if you're interested in research, that's a great place because you have a lot of already preset, whether if you're doing clinical trials, then they're probably familiar with how to go about it. And there again, a lot of other benefits to being in an academic institution. Then you have private practice, which can be like a solo practice. Say tomorrow I want to start my own practice. So if I'm the only dermatologist, it's my own solo private practice. Whereas if you want to be within a group setting with other dermatologists or even other plastic surgeons, then you're in a group private practice setting. Then you have multi-specialty groups. So the group that I'm with. So if you guys have heard of, big groups such as Kaiser, I'm with Providence. So these big groups, and the benefit about being in a setting like that is it's very referral based. So it's actually relatively easy to stay busy because people or the other physicians from pediatrics or maybe internal medicine, they then refer patients to you. So it's very referral based. So there's a good chance you're going to stay busy. And then there's private equity backed dermatology practices. So this happened in the last few years or so, where so big groups that are private equity groups went ahead and bought a lot of individual solo practices. And then now they run it in a very, much more efficient way. And again, there are pros and cons to being in that kind of a setting as well. So I was told to share what my typical week or day looks like. So I work every day, and although most dermatologists I would say works maybe 4 days a week, and I do work 5 days a week, but I have 2 half days off. So I have 2 mornings off. So Mondays and Wednesday mornings, I have it off, and I start clinic at noon, and I work noon to 5. And then the other Tuesday, Thursday, and Friday are my full days, like typically 8:30 to 5 or so. But then Friday afternoon, that's when I do all my procedures, all my surgeries. So it's still super fun. And in terms of how many patients I see, so even though I don't work that many hours per se, I still see more than 100 patients just because dermatology is very fast paced. So in a typical day, we usually see about 4 patients in an hour. So our appointments are 15 minutes per patient. So during my full days, when I'm here from 8:30 to 5-ish, I see about 30 patients or so. But then on my half days, when I'm here for even 5 hours, I see 20 patients or so. I was just telling her that I was a couple minutes late because I was finishing up my last patient, because today's my half day, but I still saw, I think, 18 patients or so. I do not take any calls, and I do not work on the weekends, which is, something very precious to me. But that being said, there are some dermatologists who work on the weekends or who take calls as well.
So you'd probably say that there's like a really good work-life balance being a dermatologist, correct?
Yes, absolutely. I don't think that should be the sole reason why one should go into dermatology, because, when we make that decision, right, which specialty to pick, it's so important to realize that your training is also your residency is only like a 4, maybe 5 or 6 year thing. But whatever specialty you pick, you're going to do that for the rest of your life. So you
Mhm.
really need to have good reason to pick what you're doing. If you're just doing it for easy hours or, the financial incentive, honestly, at some point, if you're burnt out or if you're not happy with what you're doing, it's kind of not worth it. So I'll tell you in a little bit. Oh, there you go. That's my next slide. I'll
Mhm.
tell you why I like dermatology so much. And, I always say this, that when I was a medical student, at the end of every medical rotation, I would go up to my attending, especially my female attendings, and I would ask them this question that if you had to do your medical training all over again, would you have picked the same specialty that you picked? And almost everyone would say yes, but sometimes I saw in some specialties, they would take a long pause to say yes, but almost always dermatologists were super happy and they were like, yeah, 100%. So I'll tell you loud and clear that if I had to do my entire training the last 14, 15 years all over again, I would 100% do it again, knowing that I was going into dermatology because I genuinely love my work so much. So the reasons I love dermatology a lot is mainly because I see so many patients. And to me, the kind of person I am, I love that. I love seeing 4 patients in an hour, that kind of thing. And with these high volume of patients, then we get to make build long-term relationship with our patients. And then not only, it's the mom that I might meet for the first time. Then they'll bring their kids over. Then they'll bring their grandparents over. So it's like the entire family you end up taking care of. And I love talking about my toddler, my 2-year-old daughter, with every patient, and I love learning about them. So it's this long-term relationship, which is probably for me the best thing. I like the fact that there's a good amount of medicine as well as surgical cases. Like honestly, it's never very boring because I walk into clinic in the morning and I have no idea how many biopsies I'll do one day. And biopsies are, more hands-on little procedures, or it might be even simple things like little cysts or milia, which I know they're like very simple, but at the end of the day, when you're able to remove it, the patients are so happy. So kind of being hands-on, that makes it really fun. And then, of course, I'm seeing a lot of medical cases too. And then this next point, people are truly bothered by like things that show up on their skin. And again, depending on which stage you might be in your medical training, like when you go through maybe internal medicine rotations or peds rotations, if someone has diabetes or high blood pressure, a lot of times, unless they have some true symptoms, those are kind of just numbers and people don't care if your blood sugar is super high or not. But if anything pops up on their skin, they're always so like worried about it, or they'll come to you. And if you're able to take care of it, again, people are usually very happy. And trust me, if someone's super, even if it's a simple thing like super itchy and they can't sleep at night and you're able to help them, it truly makes a big difference. And I can say that because whenever I am itchy or my daughter is itchy, it can be a big deal sometimes. Then the other thing is, yeah, teamwork with other medical providers. So I work in a multi-specialty setting where I work with other pediatricians, I work with OBGYNs, and it's the team effort where we take care of our patients as a team. And, there might be other medical conditions that my patients have, and we talk to each other and decide the best way to have like a patient-centered medical care. And then the other thing I think I'm going to talk about in my next slide is other than just practicing medicine, there's also a ton of other things you could do as a dermatologist. And I'll go into that, I believe, in my next slide. Or, oh, I deleted that slide. Oh no, give me 1 second, guys. I had a very good slide on like all the different types. Oh, okay. Well, I'll just tell you guys then. So basically, I had this nice slide that I made on all the different things you can do as a dermatologist. So you can do medical dermatology where you're taking care of things like acne, eczema, psoriasis, skin cancer. We do a lot of our checks and checkups are just skin cancer screening, where we look at the skin from top to bottom to pick up any skin cancer as a preventative skin checkup. Or then we can do surgical dermatology where we excise skin cancers or even benign growths such as cysts and lipomas. Or we do something that we call Mohs surgery, MOHS, Mohs surgery, that was named after Dr. Frederick Mohs. That's a special kind of surgery to treat skin cancer. Or we like excise things like keloid and other benign growths. Then there is cosmetic dermatology where, Botox and fillers and chemical peels or laser. Also, you can use laser for a lot of medical indications, so not just like cosmetic purpose. And even Botox, I don't know if you're aware of this or not, but Botox is also FDA approved for hyperhidrosis, so excessive sweating. And I have patients that I do Botox in their armpit and even their palm, and they get a good response for six to 8 months or so. And then there is other things that you can do as a dermatologist. So you can be involved in clinical trials. You can work with the pharmaceutical industry. You can be a key opinion leader. You can be a thought leader. You can be a consultant. You can also do like bench work, like bench research, and again, more so in academic institution. When I was training, I had some of my attendings who actually still had a lab. They like to run a lab part time and practice the other time. And so basically, there are a ton of different opportunities, and totally depending on what you want, you can always have these other sort of side gigs or side opportunities that come out. You can write for a magazine, again, the skincare stuff. I started doing a bunch of social media stuff over the last few months, ever since the COVID pandemic hit, on TikTok and Instagram and whatnot, educating and whatnot. But that brought in a lot of other opportunities where you can then be spokesperson for different brands, or you can do these dinner talks for like biologic medication or things like that, just to educate other dermatologists or even other non-dermatology physicians. So basically, there's a ton of other things that you can do, not just practicing and being in clinic, just depending on whatever makes you happy. And then the other most important reason I love dermatology so much is the work-life balance, right? I don't know why it's the culture in medicine where we're not allowed to say that, oh, my family is equally as important. If anything, we're always meant to be like, oh, my career is the most important thing. But no, at the end of the day, your family matters the most, and you get to do whatever makes you happy. I have friends, I have one of my closest friends, she's a pediatric neurologist, and her hours are pretty rough, but she loves it. And if you love it, then go for it. But like I said, you should pick a specialty depending on like if you think you're a good fit for, or if that specialty is a good fit based on your personality too. So I love working really hard during the weeks, but then on the weekends, I spend time with my 2-year-old toddler, my dog, my husband, my family, whatnot. So do whatever makes you happy. Okay. So that was my first half of the talk. So if anyone has any questions, I'm happy to take them.
Um, so talking about residency, I've heard that like dermatology is one of the most competitive residencies out there. So how would you recommend preparing to apply for a dermatology residency, and what would make a competitive applicant?
Yeah, so it's true. So dermatology is one of the most competitive residencies, and it's also probably because they don't have as many training spots, training programs, and there is a pretty good demand for it. Like a lot of people want to apply into derm, but because of the supply demand mismatch, it ends up being very competitive. So I was actually part of the admission committee at University of Miami when I was one of the chief residents there, and the numbers, like your scores, your board scores, or those things, they matter, but they matter to some extent. They're used more like for screening purposes, right? But at the end of the day, it doesn't matter if you have super high scores or not. As long you have like a good enough score, then it comes down to like your individual story, right? Like what makes you different from all these other people applying, right? So most programs love to see leadership skills, because they want to be proud of you once you're done training with them. So if you have like started some sort of organization, or if you've been actively involved in leadership role, that definitely, it just highlights your application, and like people have good questions they can then ask you about that. Definitely research, research, research. And it's only getting crazier and crazier, because so many people going into derm, they have like this impressive resume with like, I don't know, 10, 12 number of papers and whatnot. Again, to me, I also think quality matters more than quantity. So if you have some strong publications, so I think for me, what helped was I had pretty good publications in Nature and Science and whatnot. Even though I wasn't first author, but I had done significant amount of work and I had those publications, I think that stood out more than all the other smaller research projects that I had done. But people still like to see that you have strong interest in research and have a strong resume. Another important or common question we get is it important, or do you have to take a year off? That's a very interesting question, because I have mixed feelings about it. So both at Harvard, when I was a medical student, and at University of Miami, the culture was that, yeah, they would almost always tell you take a year off. But especially in my year at Harvard, a lot of people did not take a year off because we just didn't want to, like just to make your resume look better. Like we didn't want to. But what that meant was, I remember that last year, it was between my third year and the first half of fourth year, I worked really hard. I was sleeping like 3 or 4 nights hours a night, and I tried to crank out as many publications as I could. I was lucky enough that I had multiple faculty members who always had small research projects going on. What I did was I would always proactively email my attendings, email my faculty, and ask them even simple things like, do you have a case report that I could write up, or do you have a case series? Like maybe you have seen some interesting cases in clinic. I'll just write it up for you, and things like that. And you'll be surprised how many times people have such opportunities that they don't have the time to get to. But if there is a eager, motivated medical students, they're always happy to give the project to them. So yeah, definitely get as many publications, but also the good ones that matter more. So if you're able to get publications in the JAD or JAMA, also your mentors, like if you are at places where you have mentors that are kind of well known across the country, that definitely helps a lot. And even if you don't, like, just reach out to mentors either through say the American Academy of Dermatology website or through the Skin of Color Society website. You can always identify mentors and reach out to them, even if you attend a different medical school. But just reach out to them and be like, hey, I have an interest in, maybe find out like what area they're interested in. So if you see someone who does a lot of research in acne or something like that, reach out to them and be like, I'm really interested in like learning more about acne conditions. I see you do a bunch of clinical trials. I was wondering if there's any way for me to be involved, or is there anything I could write up for you? And or is there a review I could do? And so many times, attendings have ideas that they want to get to at some point, but they just don't have the time. So they love it when someone else is able to kind of jump in and help them out. So publication, volunteering, again, you don't have to do volunteering just for your resume to look good, but more so again, if you're able to show a genuine interest, right? Like if like for me, I like volunteered in like India and Kenya and US and Canada, not because I was just like checking off boxes, but more so because I grew up in India and then I came to the States and I kind of wanted to compare the healthcare system in different countries or in different parts of the world. So that kind of went along with my story, right? But not like, oh my God, I just randomly went to all these different countries. So as long as you have something that makes you unique, that makes you kind of shine above the others, because people want to meet interesting people. And then at the end of the day, a lot of it comes down to the interview process. Because you might look great on paper, but then during the actual interview, people want to just see if you're a normal person. If you're too hyper, too excited, sometimes that's a red flag, so it's all about moderation. Just be genuine, and people can see through that, like just be genuine. And if you really really want something, like I really wanted to go to University of Miami, so then I made it very clear to them during my interview process that, look, I'm going to rank you number one because I would love to come to this program, and here are my reasons why. And I told them my reasons, and then it worked out. So yeah, just be normal, just be genuine. And it's a rough process. If you're sad or upset, if people told you something, it's expected. I mean, honestly, I can't tell you how many times I cried, I doubted myself, like all that kind of stuff. But I think it's almost normal. Everyone goes through that. But once you're done with your training, especially, it is 1,000% worth it. So just keep hustling, keep fighting, but you'll get there one day and life is going to be good. I promise you. No matter where you train from, it's going to be great.
Mhm. Another question I saw, but thank you. That was wonderful advice. Thank you so much. What are the most important qualities of being a dermatologist? So, like, what would you need to see in yourself before going into dermatology?
I think, what really helps is if you're a very focused person and if you're very efficient, because like I said, derm is very fast paced. Like the number of patients you're seeing, the number of procedures you're doing, if you're someone who tends to forget things or you're kind of all over the place, it's just going to be much more hard, like chaotic, because you just have to like know, okay, I saw this patient, they had 5 different problems. Either you like write up your note right away, or even if you like work on it later, you have to be organized enough in a timely fashion that so that you're not getting backed up. Because like I said, you go 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 in derm, like you can't really slow down much. And then, it also depends on your personality. Like I was saying, usually a lot of people don't care where you trained from. A lot of people don't care if you were probably the smartest kid in class. What they care about are like your bedside manners and like how you interact with people. So dermatology is definitely one of those specialties where you just have to be comfortable making others comfortable. I don't know if that makes sense, but like basically people want to be able to trust you, like your stuff, but at the same time they want someone very caring, very friendly. And those are skills a lot of time we don't learn about that during our training, because we're always told to be okay, just be very good at what you are. But it's so important to just kind of also have that human side, like bedside manners that matters a lot. Yeah.
One last question before we get into the case study. Someone asked, did you experience any significant hardships as a woman of color in residency, med school, or work?
Oh yeah, 1,000%. It exists every single day. I'm not even exaggerating. It exists every single day. Um, Big thing. So for me, one of my biggest thing was I was on a visa, right? So when I was applying for medical school, when I was applying for residency, I couldn't even apply to a lot of programs that are like such as like the California schools, the state schools, because they don't even take applications from non-US citizens. So that was one thing. But then as a woman of color, yeah, I would say the most I have actually felt that is actually now after finishing my training because, I'll walk into a room, I'm younger looking, and now we have masks on. But prior to that, I probably had makeup on, or I like to wear cute clothes, cute dresses, cute heels. And you have to be careful because sometimes people will like almost be like, yeah, you look too young to be a doctor, or like, oh, have you done this before? It doesn't really just end during your training. Even when you're on your own in practice, people will ask you all the time, like, have you done this case before? And you're like, yeah, I have done like 2,000 biopsies so far, but they'll still ask you that. And I've seen that difference. Like, I have a male colleague, and he'll walk into the room and he'll be like, oh, that's a benign growth, totally fine. And the patient's like, oh, okay, perfect. I'll walk into the room, say the exact same thing, and they'll be like, are you sure? And I just kind of have to go through the whole process of reassuring them and whatnot. So that exists 100%, 1,000%. And there are days where it'll get to me and I feel very sad and I feel very upset, but then I'll give it my all, right? Like to me, I want to make sure my patients are happy and I don't discriminate. Now, whether I am being discriminated or not, it's not in my hands, right? So that's like it's not in my hands, so you can't let it get to you, but it's going to happen. No matter which part of the country you are in, it's going to happen. But just don't try not to let that get to you, because it's not personal. It's just sometimes maybe people have had different experiences, or maybe they're just not comfortable. I have an accent, right? And so I get a lot of people are like, oh, where are you from? And it's not that they have any ill intention or bad intention. It's just that they're not very comfortable and they're trying to be nice, but they might end up saying something which makes it a little awkward. But it's okay. You just smile and you joke and you move on.
Right, right. But thank you so much for sharing that with us. Like, especially now that there are a lot of aspiring female physicians, like it's good to know that there are leaders in the field and like people are doing it and it's totally possible. So that was really good like encouragement for all of us out there. So we appreciate that.
No, absolutely.
So did you want to hop into the case study?
Sorry. Oh, yeah. I was going to go over some quick rashes, some fun rashes. But again, at any point, if it's more helpful for me to talk about this kind of stuff or just dermatology, just feel free to interrupt me and, ask your questions. I made a few slides on some case studies just for fun. So I don't know if people are able to sort of reply, but say I have a 6-year-old patient who comes in with these red patches at the back of the knees that are very itchy. Can you guys think of what it could be, or what are the questions you would ask the patient? We'll give them like a minute or so.
Mm-hmm. Because usually there's like a little bit of a lag where we're like 30 seconds ahead of the
Okay.
actual, yeah. So, but while they're waiting, I can just read some of the comments that people were saying. Someone said they're jealous because you're pretty. Um, There were some other really good questions in here that we could go back to at the end, like,
Yeah, or like you said, like I said, I mean, based on the some of the shadowing sessions I've done, I feel like it's been more helpful for me to just talk about derm or like answer questions. So if that's more helpful for others, I'm happy to do that. If you think case studies are helpful, like whatever makes sense for you guys,
mhm.
I'm all yours till 6 o'clock. Well, 6 o'clock PST. Then I have to go be with my daughter.
Aw. There are some questions pouring in. So the question that they would ask is any allergies? One person predicted eczema. Was a child playing outside because of poison oak? How long has the rash been present? Recent activities? Is it itchy? Um, do any other family members have it? So,
Oh, great. Great. I mean, so many people are thinking along the right track. And yeah, so this is eczema. And so those questions are great. Even things like, yeah, like what are the other things? So patients with eczema or kids with eczema, even other anything from the environment can trigger the rash and make it much worse, and then cause contact dermatitis. So it's important to always ask them, yeah, what have they been putting on their skin? What other activities have they been doing, going outside or not? Family history, that's very important because atopic dermatitis or aka eczema usually tend to have a family history too. And then we classify them as acute, subacute, and chronic. So acute eczema is typically less than 2 years of age. You get these really juicy looking rash on the cheeks, and then also on the extensor surfaces, so on the elbow areas, on the knee area. And usually little kiddos, they can't really say they're itchy, but they're miserable. They don't sleep at night. They're always crying at night. That's how you know that's an acute flare up of eczema. And then subacute is more from like 2 to 12 years old stage, where because you've had these lesions for a long period of time, people tend to like scratch them, and then they become more what we call like lichenified. That means they get much thicker. And now the distribution changes a little bit. It's more so the antecubital and popliteal fossa, more flexural areas rather than extensor surfaces. And then chronic eczema. So you can see eczema even in adults. And I see, especially in Southern California, we see this a lot. So anytime it's dry outside, that's a big trigger for eczema. So that's when you see more like hand dermatitis or dermatitis around the eyes. That's super common that I see, and especially with COVID and everyone's washing their hands. So many people get this super itchy, scaly rash on their hands, and even the end of their fingertips can get really dry, and they can get cracks and fissures that are then painful. But yeah, so the distribution kind of changes, and the presentation also might differ. And then in terms of treatment, sometimes it can be managed by primary care physician or pediatrician, but other times you have to go to dermatology. The most important thing is moisturize, moisturize, moisturize. Just simple thing about moisturizing can be so helpful because, like I said, most of the time these rashes break out when people are dry. So things like even like hot showers, even though it might feel great when you're taking a hot shower, when you come out of the shower and then you're drying your skin gets super dry. That's why if you're taking hot shower, then people start scratching their skin or they break out into a rash. So we always say take lukewarm shower for a quick, like a 5 minute shower, and then moisturize, moisturize, moisturize. And when that's not enough, the first line treatment is to give topical steroids. I just put an example of one which is very common that we use called triamcinolone. That's for the body. You want something not as strong for the face because the skin on the face is pretty thin to begin with. So we typically use hydrocortisone for the face. And then there are other non-steroidal topical medications that we could use too, such as tacrolimus or crisaborole. Those are more expensive, but they don't have some of the side effects of topical steroids. Sometimes if they're itching or if their rash is really, really bad, I might even do a short course of oral steroids, so oral prednisone for about a month or so. And then there are other non-steroidal oral medications that are available too, such as cyclosporin, methotrexate. Basically, these are stronger medications, but again, they might have side effects on your liver, on your kidney. Then you can do UVB light therapy. So phototherapy is actually pretty effective for itching or just like rashes. And then one of the most newer medication is dupilumab or Dupixent, which is a biologic medication for atopic dermatitis. It's amazing. I actually have a lot of patients on this medication because it's very different from the psoriasis biologics such as Humira and Enbrel, because it's not like a true immunosuppressant. It doesn't suppress your immune system. It's an immunomodulator. So it changes, it's very targeted, and it changes your immune system in a way that it helps with the eczema but doesn't have some of the other side effects that the psoriasis biologics have, such as you don't have to do any blood tests for this one. You don't have to check for TB, or you don't have to check for hepatitis, because the dupilumab doesn't increase your risk for infection or cancer. And again, if my patients fail some of the other things that I have listed on top, I go straight to this injection, and most people just love it. All right, anyone have any guess what this is? So I'll give a little hint. So this is someone with eczema, and now they have something going on top of it.
Oh wow. Do you get cases like these often?
Sometimes, yeah, yeah. This one, yeah.
What are typically the pain levels for people who come in like this?
So it depends on location. So the fingertips, yeah, that tends to be very painful. Around the mouth, that area can be very painful. But it depends. But more than pain, it's like limiting their daily activities. Because imagine if you have something going on like this going on your hands, you're not able to use your hands for the regular day-to-day regular functioning every day. And this, I'll just move on in the interest of time. This is a Staph aureus super infection. So that you call this impetigo, but basically it's a overlying bacterial infection of, some eczema that you might have in the background. Treatment for this is actually oral antibiotics. And what's important is when you have super infection like this, just treating the actual infection actually leads to improvement of their underlying atopic dermatitis. So depending on how bad they look, this honey color crust, that leads us to think that, oh, it's probably super infected, and we do a short course of oral antibiotic. This is something more rare. I saw at least 6 or 7 of this during my training, but luckily we don't see a whole lot of this in private practice or in practice in general. But this is eczema herpeticum, which is basically people with underlying eczema or atopic derm. If they have super infection of herpes, then they have this rapid dissemination of herpes, and people can be very, very sick. Very, like, this is considered one of the true emergencies. So when I was in training, we actually used to get quite a lot of calls in the middle of the night, but this was one of them. We had to go in no matter what. And sometimes, I mean, almost always, they get admitted to the hospital for IV antiviral. Okay, this is a pretty common one. I bet even out of the audience, I bet a lot of people probably have this one. So this is Keratosis pilaris, which you see these little dots, red dots on the arms or even the thighs, and in little kiddos you can even see it on their cheeks. It's very common, more than even, again, a lot of patients with eczema or atopic dermatitis have it. Even though it's super common, it's actually very hard to treat, and we always have to like sit down and give people the right expectation. The two things that help the most is to exfoliate the skin with like a salicylic acid or a lactic acid based cleanser, or even like the face wash that you have, you can just put it in that area for the ones with salicylic acid or lactic acid. And then the other one is to use ample moisturizer. So urea cream, sometimes it's prescription strength, but other times it's over the counter. That helps, but any good moisturizer is pretty good enough, and it helps more than the red bumps. It helps with that texture, because sometimes you can just close your eyes and feel it, run your fingers or over your skin, and you can feel it. And with the moisturization, that texture kind of changes and becomes much more soft. There's also this fancy kit that you can get from this company called Glytone. It's $68. It's a little expensive, but a lot of people love it, so worth it. Then this is another thing I see probably at least 3 patients with it every single day because it's so common. So this is seborrheic dermatitis, which is essentially dandruff on the scalp, but it can involve the face, the ears, and on the face, it's typically in the seborrheic dermatitis distribution, which is above the forehead, along the nose, around the mouth, and then even on the ears, sometime on the upper chest or upper back too. Tends to look like very greasy, like pink color patches and can be scaly sometimes. We typically treat them with antifungal shampoo for the scalp, and then antifungal, even antifungal cream for the face. But most often we'll do a short course of, again, or topical steroid for the face or topical steroid solution for the scalp. Yeah, so the treatment is ketoconazole shampoo, which is antifungal shampoo. It's super safe. I usually tell my patients you can use it like once a week for the rest of your life, theoretically, but most people it does get better on its own. And then there are some over-the-counter variant too that you can alternate with. And then the topical steroids are more so only when it's very itchy and very red. Then the topical steroids are helpful, but again, it's important to use them for a short period of time because otherwise they can cause skin atrophy, so they can cause thinning of the skin. So they're used more like during an actual flare-up, but when things are under control, you just go back to the ketoconazole shampoo. And then there are also some non-steroidal medication, and I think only like a couple times I had to do actual oral antifungal just because the cases were so severe. All right, this might be hard for most of you. So this is this mildly itchy rash. It's called Pityriasis rosea, where you have this Christmas tree pattern on the back, especially. Again, typically you see it in healthy adults and adolescents, about like 10-year-old to 35-year-olds. Lasts for about 3 to 8 weeks or so. It's thought to be because of viral cause. And some people might even have like headache or fever before they get this rash, which kind of breaks down like a Christmas tree on the back. For a lot of people, it starts with just like one patch on their belly or something like that, just like one patch. We call that the herald patch. And then it leads on to the more generalized eruption where, if you can see like this, it's like a Christmas tree, right? Like the rash distribution. And it can be itchy sometimes. You don't really need to treat it because it's self-limited. It's going to get better on its own, but sometimes we might do topical steroid just for more symptomatic relief. And there's been some evidence showing that antiviral medication can help more so towards the beginning when the rash is just breaking out, is starting to spread, because again, it's thought to be because of herpes. This is tinea corporis, aka ringworm, which is very common. Typically, you'll see this like a pink scaly rash, but then it'll have like the central clearing, which is helpful. That's how we can tell. And then if it's involving the hair follicles, then you can get these like little red dots or little white pustules too. Treatment is most of the time just topical antifungal cream, but sometime if it involves the hair follicles, then we have to do oral antifungal. Oh, another key thing, because sometimes it's hard to tell the difference between ringworm or tinea corporis and a form of eczema known as nummular dermatitis, because they can look very similar. But the way you can tell the difference is if a patient were to use topical steroid for a fungal infection, it'll make it much worse. So this is an example of nummular dermatitis, so which is, completely different mechanism. This is not infection. This is more inflammation on the skin. So this is more of a variant of eczema, but it can be just like circle. So very similar to this previous tinea photo. And sometimes we can do a bedside scraping. So we can just take a little bit of the skin, scrape it off, and look under the microscope to look for fungal elements. Other times, very rarely will I do a biopsy if I really can't tell the difference between the two. But if we prescribe them topical steroid and then the patient calls me back and they're like, oh no, that actually made my rash a lot worse, that's how I know it's more fungus rather than nummular dermatitis. These are warts. These are super, super common. The most common treatment is to do liquid nitrogen treatment. But another important point is most of the time, they don't really go away just with one treatment. We have to bring them back once a month kind of a thing, and then it responds well. Another thing I use a lot is intralesional candida. So it's basically candida, components of candida that you inject underneath the wart, and then it causes an immune response, and then your own body sort of generates a response and tries to target the warts. And in my experience, it probably works better than the liquid nitrogen. And then there's also evidence that just the HPV vaccine also helps if someone has numerous warts. This is a quick little slide that might be helpful for most people. So if you get minor cuts or burns or like, random skin ulcers, try to avoid Neosporin, especially triple antibiotic, because in our dermatology world, we see a lot of contact dermatitis, so allergic reaction from Neosporin and triple antibiotic. So we almost always say that just put Vaseline, nothing else, just simple petroleum jelly Vaseline. Only if there is any evidence of infection, then you might need either topical or oral antibiotic. And like I said, not huge fans of triple antibiotic cream. We like something called mupirocin, which is more of a topical prescription medication. Also avoid hydrogen peroxide. A lot of my patients will be like, "Oh, I washed it real good with hydrogen peroxide," but then that irritates your wound and makes it the wound will take a lot longer for it to heal. Then keep the wound covered with a band-aid unless you're allergic to a band-aid, allergic to glue from the tape. Then you can just put gauze and paper tape around it. And also if you have a blister, avoid debriding the blister because the roof of the blister actually acts like a natural band-aid. So it's best to just let it be, just keep it clean, put Vaseline and keep it covered. Okay, those were my quick little tips about common rashes. So we can go back to any other dermatology questions you guys might have in the last few minutes.
Um, I'm gonna read the comments real quick. So, a question about the case study kind of was, since moisturizing is a big solution for a lot of cases, what happens to patients who have sensitive skin who break out from creams and oils?
So what's very important and that's a very good question, by the way, but what's very important is to look at the ingredients in your moisturizer. So first of all, anything with fragrance is not ideal, especially for people who have very sensitive skin. I think the one of the most common brands that I recommend for my patients with very sensitive skin is this brand called Vanicream, Vanicream, because almost all their products are like free of fragrance, free of any dyes or anything that could possibly irritate your skin. So using that, then looking for ingredients such as oatmeal or ceramide in your moisturizers, that helps a lot too because they provide a better barrier for the skin. And then there are different kind of consistencies. So you can use lotion, which is more water based, versus ointment, and thicker creams, which is more oil based. And even though ointments and creams are better than lotion, they're also a little bit more greasier. So some people might not like it. So that's why I tell my patient, you should use whatever you like because I'd rather you use something rather than nothing. So I give a lot of samples and I just have them like, oh, as you guys can see all my samples in the background. So I just give them a bunch of different sample and tell them, see what works for you. Because a lot of time, there's no one product out there in the market that will make everyone happy, right? So you just have to try and see the one that works for you.
Um, if a wart hurts a lot, can you perform a surgical procedure on it to remove it?
That's a very good question too. Yes, so sometimes very rarely will we do a biopsy to remove a wart because A, you could get a scar from doing a biopsy to remove a wart, and B, the wart still comes back that way. So usually I won't remove a wart like that. I'll try to treat it with the liquid nitrogen or the candida. And if it's super recalcitrant, if it doesn't go away even after like 2 or 3 months of treatment, then I'll go ahead and actually remove it. But they tend to come back.
So, personally, what made you choose dermatology?
Oh, I think I went over that slide. I'll just leave it at this. I
Mhm.
think dermatology, to be 100% honest, I have always, and I'm being 100% honest to, I don't know how many viewers you said, like hundreds and thousands of people, but I was one of those people, I come from a very small town in India. I had these goals of like trying to do the best with my career. I wanted to attend Harvard Medical School no matter what. And I eventually got there. I was super happy, but during my first few months, my first year at Harvard, I lost my dad in the middle of the night. He was in India, and I remember I was studying for my anatomy finals, and I got a phone call in the middle of the night from my brother, and he said, we lost dad. And when that kind of stuff happens to you, when you lose your loved ones, you then start questioning like what truly makes you happy. Because prior to that, I wanted to do neurosurgery. I wanted to be like this hardcore, like, I don't know, female surgeon and whatnot, because I thought that was going to make me happy. But then after I lost my dad, I realized, to me personally, my family matters a lot. I really like simple things in life, such as like, I don't know, going for walks with my family and looking at the flowers and looking at the sky and things like that, which you can do no matter which specialty you do or whichever kind of medicine or whatever lifestyle you have, career you have, not only medicine but even outside medicine you could do, but sometimes it's hard to do it if you're in a very rigorous kind of a setting. So I figured, to me, I wanted something that I enjoyed so much that I would be happy doing. And my main thing is, right now when I wake up in the morning to come to work, I actually enjoy it. I love it. When I drive to work, it's never like, oh my God, today I have to go see 20 patients or 30 patients. It's more like, yeah, it's kind of fun. The day's going to go by so quickly. Oh, I wonder who I'm going to see today, or I wonder what kind of procedure I'm going to do today. So, based on my personality, I feel like this is a good fit. I'm genuinely very, very happy, and I have plenty of time for my family. Earlier this year, again, my mom was very sick. We almost lost her, but she's doing fine now. But again, with my current schedule and with my kind of work that I do, I was able to kind of be there for her, even though she's in a different country, so I couldn't go there, but I was there virtually the whole time. You know, I was also seeing patients, and in between that, I was able to schedule it in a way that I was still there. I was able to talk to my mom's physician in a different country in between my patients here, which probably wouldn't be that realistic. Say if I was going to do a surgical case that would take me 2 3 hours, right? So you got to do whatever makes you happy, because at the end of the day, no one cares about what you do other than you and your family. Trust me, when you're at your deathbed, not to get too deep, but when you're on your deathbed and you look back, you want to have a life where you've been happy more than a life where maybe you made a ton of money or a ton of prestige. You want happiness. That's so much more important.
Right. That's fantastic advice. Thank you so much for your time. We really appreciate you coming on here and talking to us about your life and procedures you do. And most importantly, like advice on how to pick our career, because most of us are at that stage in our life where we're deciding, is medicine for us? What type of specialty would we want to do? So, all that advice was very, very helpful. And we are so thankful for that. Um, just to wrap up, would you mind if I gave them your Instagram handle if there were any additional questions that we weren't able to answer in the time?
Yeah, absolutely. I'm pretty good. I go through these random spurts. Like sometimes I like respond to you like immediately within an hour or so, and sometimes it might be a few days till I get back to you. But yeah, feel free to reach out to me. And another thing is, no matter what you pick, because I have some super close friends that are doing pretty intense specialties, but they're happy doing it, you know. So and it's fine. And at the end of the day, if you go into medicine, it doesn't mean you have to practice medicine for the rest of your life. There are so many other side opportunities that come out too. I know so many physicians who are now trying to like they'll get their initial sort of it's good to be in medicine in the sense that you have a secure way of, having your salary and whatnot, right? And then you can take that money and invest doing real estate and so many other things, and you don't have to keep practicing for the rest of your life. You could make life pretty flexible too, depending how smart you are with the way you handle your finances. So no matter which specialty you're doing, I'm sure you can always make it work out. You can always have a flexible schedule, and you don't have to work 5 days a week. It's just what you choose to do.
Right. And that's amazing advice. So, like, thank you so much. Like, guys, like, take that to heart. I know I'm like taking all of what you're saying to heart and putting into considerations. But again, thank you so much for your time and thank you so much for all of your advice. And make sure that you guys tune in next week for the virtual shadowing session next week. So I hope to see all of you guys there.